So, we are talking about first, these are most of your cardiac meds. These are mostly your antihypertensives. Antihypertensives, okay? So you have, look at this, it's A, B, C, D. A, B, C, D. All of these are antihypertensives. So you have ACE inhibitors, your ARBs, your ARBs are your angiotensin receptor blockers. They are your ARBs. Your beta blockers, calcium channel blockers, digoxin, dilators, and your diuretics. This drug classification focuses on lowering your blood pressure by specifically working on the heart. So they're all of them, all 6 of them, okay? So if you ever come across questions like that, ACE inhibitors, angiotensin receptor blockers are your A's. B, beta blockers. C, calcium channel blockers. D, digoxin. D, dilators. And D, diuretics. A, B, C, and 3 Ds. So that is what it is. Antihypertension that works specifically on the heart. All of them focuses mainly on blood pressure, except the digoxin focuses on what?
Heart rates.
Heart rate, right? That's the only, all of them focuses on blood pressure. The digoxin lowers the heart rate, right? So we will get into that more and more. But when you get confused about those blockers are antihypertensives, and they tend to lower the blood pressure by working on the heart. Let's just say that.
So all of them work on lowering the blood pressure except digoxin.
Yes.
Okay.
So you ever see them? Okay. Now let's look at them one by one. So you have ACE inhibitors, okay? They lower the blood pressure, but not the heart rate. The first drug of choice for your ACE inhibitors are your usinopril, right? Usinopril. See when I type? So your ACE inhibitors are mostly those that ends in prils. Prils, okay? Usinopril. So ACE inhibitors lowers the blood pressure, but not the heart rate. So they end in prils, like usinopril. How does it do that? It does that by blocking the RAS system. So aldosterone and sodium, it blocks that. It prevents the body from retaining water. So if there's less water, there's less blood pressure, right? Because the more fluid you have, the harder the heart has to work to pump, right? Because there's too much fluid. If you have fluid overload, right? That's the RAS system, right? The RAS system, what does it do? Put a note there for yourself. Refresh your memory about what the RAS system is. However, these ACE inhibitors, they block sodium. If you're blocking sodium, What does sodium attract?
Water.
Water. Water.
So if you're blocking sodium and aldosterone, they both attract water.
Mhm.
If they're attracting water within the body, you will have fluid overload. Like in heart failure, right? You have too much fluid that the heart cannot pump it all out, making your blood pressure elevated. But ACE inhibitors, they block your sodium and your water retention. They block it. So once it's blocked, the body could not retain water. There's no water retention. So the blood pressure then drops, right? Questions? Where is heart failure? I'm looking for heart failure for a minute. All right. You see my little diagram here of heart failure? Okay. This is heart failure. It means that if there's too much fluid in the heart will have a harder time to pump, right?
Mm.
If the heart has to exert so much effort, especially at the left ventricle, to pump, what happens? The blood pressure increases. So your ACE inhibitors then is blocking sodium and aldosterone to decrease fluid retention within the body. However, in an effort, because there's always a balance, right? If they're blocking sodium, okay, what is coming out? It's sodium and the partner is who? Potassium,
Potassium.
right? So if you're blocking sodium, who's gonna let loose?
Potassium.
Potassium.
Potassium, right? So if potassium is loose, what are you gonna have?
High potassium.
Hyperkalemia.
Hyperkalemia. So for your ACE inhibitors, they block your sodium, they block your aldosterone, so there is no fluid retention. However, blocking the sodium allows the potassium to go out. So one of the biggest problems with your ACE inhibitors is hyperkalemia. So potassium levels are elevated. So this is for your prills, okay? ACE inhibitors that ends in prill. Yes, they lower the blood pressure. This type of medication is usually used in heart failure where there's too much fluid. So, and the pressure is so high because there's so much fluid and the body is trying to get rid of it. So the ACE inhibitors just block it to lessen fluid retention within the body. However, they're letting your potassium loose. ACE inhibitors, prills, hyperkalemia. Okay, so what do we have to remember here? Avoid pregnancy, not baby safe. There is this thing that they call angioedema. So the tongue puffs up, the tongue swells, swelling of the tongue and the face, and that causes an airway risk. The prills, they cause angioedema. So watch out for that. And just for some reason, they cause a cough. Have you ever come across a question where something about people on lisinopril and they're coughing?
Mm-hmm. Yes.
That is what it is. The prils can cause a person to cough for some reason, okay? This is the thing that's very unusual about it, but cough. So when you say a type of antihypertensive that has a side effect of coughing, that's your prils. That's your lisinoprils. That's your ACE inhibitors. So we said earlier that potassium can be elevated because potassium is let loose. So you will have elevated potassium levels and it will be hyperkalemia. Remember, potassium levels that are more than 5.0. You have to worry about those levels. So, how much is the potassium level? Normal?
3.5 to 5.0.
3.5 to 5.0. So any potassium level that's more than a 5.0, you have to worry about. So if you have hyperkalemia, are you going to encourage them to eat potassium rich foods?
No.
I had to put not. They should not be eating potassium-rich food because the potassium level is already so high. But green leafy vegetables, melons, oranges, salt substitutes, and liver are all high in potassium. You should know this because these questions are going to come up as select all that applies. So liver, okay? Liver is also high in potassium. So you have your antihypertensive, their ACE inhibitors is the very first one there. It lowers the blood pressure. They mostly end in prils, lisinopril. So then you have it is blocking sodium, so potassium is out. So you will have to watch out for hyperkalemia, potassium levels that are higher than a 5.0. So remember, no pregnancy. Angioedema is specific to lisinoprils also. And you have this cough for some reason. So they should not be eating potassium-rich foods for these people. So second A is your, okay. Second A is your, so if you look at this for a minute, to make it easier for you, look at these things that you have to remember, okay? Avoid pregnancy, angioedema, cough, and an elevated potassium level. So it's AACE, right? It also spells what? ACE, right? It also spells ACE for ACE inhibitors. Okay, AACE, avoid pregnancy, angioedema, cough, elevated potassium. ACE for ACE inhibitors.
Mr. Smith,
Yes.
Maria says she's trying to come in. She can. Yes.
Okay, 1 second.
Thank you, ma'am.
I think she's in there already. Yeah, here she is. Okay. So, okay.
It's good mnemonics.
Yes. Good mnemonics, right? It worked out good. See? No.
Yes.
AACE for ACE inhibitors. Remember that.
Daphne, is about this cough.
Yeah.
Like, I came across a question that says when a patient is taking lisinopril and
Mm-hmm.
coughing, do you say the patient should not worry that is an expected side effect, or should you tell the patient to stop the medication and contact the physician?
Yes. You have to tell the patient to, or we have to call the physician and let the physician know.
Should the patient stop, or I don't know, because
The patient should stop. The patient should stop.
okay, that's the answer.
Yeah. See, there was a question like that, right, Mubu? Something
Yes.
about half on
Yes.
lisinopril. Yeah. So you have to stop because these are things that we have to watch out for. So if it's occurring, then it can't be something good. So,
Thank you.
so ACE for ACE inhibitors, okay? Now you can't forget them. Now, your second one, if you see here, they are kind of like they're sisters. They're related. Your ACE and your ARBs. Your ARBs are your angiotensin, again, receptor blockers. So they bind. This is angiotensin 1 to angiotensin 2. What they're doing here is they block vasoconstriction. Just that. They just block vasoconstriction. So when vasoconstriction is not occurring, blood pressure decreases, right? Because you're not fighting with blood vessels. So remember, if the blood vessel opening is little and you have to put so much effort to go through, but now if they're blocking, they're receptor blockers, they're blocking angiotensin, angiotensin 2. However, just say they're blocking vasoconstriction. And because of that, the blood pressure decreases. They're always the second choice. The first choice in a treatment of heart failure is always your pills. If you see here, we put them together. But the very first choice is your pills, and then your ARBs are your second choice. These medications always end in sartan, like losartan. So ARBs end in sartans, like your losartan. So they're also antihypertensives. They prevent vasoconstriction, so the blood pressure lowers. However, the difference between ACE inhibitors and this, they spare potassium. So they're also holding on to potassium. So here they're saying avoid also potassium-rich foods. Okay, so the thing about potassium is potassium kind of like is a pump. Potassium pumps the muscle. So if you have hyperkalemia, it's a higher pump. When you say a higher pump, usually you will have muscle spasms. Potassium is always associated with muscle spasms. And then because it's pumping, it has something to do with contractility. You're looking at your EKG tracing, your ST is elevated and your T waves are up. However, just as a general rule, if your patients have either hypokalemia, potassium levels that are below 3.5, right?
Mhm.
Hypokalemia or hyperkalemia, your first priority of action always is to place your patients on a cardiac monitor. So, no matter what it is, if the problem is potassium, they have to be hooked up to a cardiac monitor. That's a priority action. So, cardiac monitor. Now, we have this thing with what we call first dose phenomenon. So what they're trying to tell you is if you're giving the patient a first dose, never leave the bedside. You have to monitor for signs and symptoms of orthostatic hypotension, right? Because you're giving an antihypertensive. So you're trying to watch for the big drop. You don't want the drop to drop so suddenly, right? You want a gradual drop in blood pressure. However, whatever it is, they're telling you do not leave the bedside if this is the patient's first dose. Monitor for signs and symptoms of hypotension. Because what if you're giving a dose that's too strong? Then you're flipping. Then the blood pressure is 200, and all of a sudden you're down to 80. So you want to watch out for that phenomenon. That's why they do not want you to leave the bedside. Stay at the bedside. Watch. Just there is no big drop. They're saying that, like, if you're in an airplane, right, and you're at 40,000 feet, you're not going to go all the way down to 10,000 feet right away, right?
Mhm.
When you're landing, they try to gradually say, okay, we're going to go down to 30,000 feet the last 4 hours. Then, so you want that. You want a gradual decrease in blood pressure. So those are the two. So the third one, the A's are done. Okay. Now we're going to go to the blockers, the beta blocker.
Miss Stephanie, before we move on, so the first dose phenomenon applies to the first two types medication classifications, I guess.
All of them. For all of them.
All of them? Okay, all right. I'm just making sure.
Yes. For all antihypertensives. Just keep that at the back of your minds.
How long do you have to stay with the patient for that?
Yeah. How long?
I would say the first 15 minutes, you're just watching, so there's no sudden drop.
Okay.
And you're also watching for yeah. You're also watching for orthostatics, orthostatic hypotension. You know, sudden changes in position. They could fall also.
Mm-hmm.
Your beta blockers. Now, the beta blockers is they block the beats. They put the brakes on the heart. So they're stopping, they're blocking the beats. What are they trying to do is they're trying to lower the workload of the heart. So they're trying to lower the workload of the heart. So they're blocking some beats. Remember, one heartbeat involves ventricular contraction also, which that is when the ventricles contract to push out all of this oxygenated blood out. Now, to decrease the workload of the heart, the beta blockers are there to block some of the heartbeats, decreasing the workload. So, the thing about that is they're blocking beta receptors. You have to remember, the way they block the heartbeat is they're blocking beta blockers. They're blocking the beta receptors. Beta receptor 1 is in the heart, right? They're blocking that because they want to put a brake on, they want to lower the heart rate. By lowering the heart rate, they're lowering the workload of the heart. So they block beta receptor 1. With beta receptor 1, they have achieved what they're there for, which is lower the heart rate, lower the workload of the heart, lower the blood pressure that way. However, because the beta blockers are non-selective, it doesn't say beta blocker, you just block beta 1. The bad thing about beta blockers is beta blocker 2 is in the lungs. So, in an effort to slow down the heart rate, what is happening to the lungs? The lungs also has bronchoconstriction because beta blockers block beta blocker 1, beta receptor 1, and beta receptor 2. It's non-selective. We cannot say you only block 1 and don't block 2. It is blocking, it has to block both. As an antihypertensive, beta receptor 1 would have been good already, right? But unfortunately, it also has to block beta receptor 2, which is in the lungs. And by blocking that, it causes bronchoconstriction. Something that you have to remember for beta blockers. So beta blockers slows down the heart rate. They lower the blood pressure, but they also cause bronchoconstriction in the lungs. An example of a beta blockers end in LOL, lol, like atenolol, okay? So LOL, so you have the 2 L's. Low heart rate and low BP is what is the goal for your beta blockers. So remember, beta blockers tend to lower the workload of the heart by blocking some of the heartbeats. As a result, there is a low heart rate and the blood pressure decreases, which has achieved your goal of an antihypertensive. However, it also is blocking beta receptor 2, which is in the lungs, which will also cause bronchoconstriction. So, what do you have to remember for your beta blockers is you cannot give them to who? Which patients?
Pregnant woman.
People that have low blood pressure.
What else?
Heart failure.
It's indicated for heart failure. No,
COPD.
not. But
Not?
COPD, it is not, you cannot give beta blockers to who? Patients that have asthma or COPD. Those conditions that what?
Those cause bronchoconstriction, right?
That will be bad for bronchoconstriction. You cannot give your beta blockers. So I know there was a question about that also. That's why. So now atenolol, unlike the other two is only basically ACE inhibitors, blood pressure, right? Then you have your angiotensin, only ARBs, blood pressure. Beta blocker has what? Pulse now, right? Beta blockers are, you're trying to what? Block some of the beats, right? Because you're trying to decrease the workload of the heart. So what are you trying to watch out for is bradycardia. When the heart rate goes so low. So before you give your beta blockers, these are medications that end in lol, atenolol. So you have the two L's there. So it means that low heart rate and low BP. So before you give, remember the B's with your beta blockers. So you have bradycardia, slow heart rate. Remember the B's with your BBs. Remember the B's with your beta blockers. So bradycardia. If the heart rate is below 60, are you going to give it?
No.
No. Okay. So no, because it will slow down the heart rate even more, right?
Yeah.
So check the heart rate before giving it. If it is below 60, you cannot give the, do not give the medication. The other part of it is it also tends to lower the blood pressure. So if the systolic pressure is below 90 to 100, are you going to give the drug?
No.
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 No, right? So you do not give the medications. And again, with orthostatic hypotension, they keep going over and over and over. So you have to remember, I don't know if NCLEX questions are, they keep going over and over and over about slow position changes. So
Yes.
yes, so just remember that with your antihypertensives, slow position changes. The other thing about another B for your beta blockers are breathing problems. So we already know we cannot give it for patients that have COPD and or asthma because it causes also, it blocks beta receptor 2, which is in the lungs, and it causes bronchoconstriction. So beta blockers, dual purpose, lowers the heart rate and lowers your blood pressure. So you have to check both before giving it. And if the pulse rate is below 60, Do not give it if the systolic blood pressure is below 90 to 100. Do not give the medications. So, bradycardia, breathing problems. Another B is, let's just say, it could get bad if you have heart failure. Watch for what is bad for heart failure. So, watch for signs of edema, crackles of the lungs. This is now an indication of fluid overload, right? You have crackles in the lungs, you have edema. What is JVD?
Jugular vein distension.
Okay, jugular vein distension. You can see it. It means that there's fluid overload. So you have rapid weight gain. So you have to report these findings to a healthcare provider right away. So watch out for, it could be bad. Watch out for what is bad for heart failure. Worsening edema, crackles in the lungs. Worsening, you have to watch out for terms like worsening or new, okay? So those things you have, because it will come up for you. The other thing, very distinct. I know this came out of your test also. Blood sugar masking, beta blockers. I know you've seen it somewhere when it says patients that are on beta blockers, they have to watch out for hypoglycemia. Why? Because beta blockers are so naughty. They mask signs and symptoms of hypoglycemia. So you will not feel cool, clammy skin, the tremors of hypoglycemia. You could get fooled, but your blood sugar has already dropped. So this is one of the very distinct. So if your patients are diabetics and they are on oral diabetic medications, we have to watch out if they're also taking beta blockers, because you will never know. You know how your diabetics, when they go into hypotension, when they go into hypoglycemia, how would you know they're in hypoglycemic state?
They're sweating.
Sweating?
Both clamming and sweating.
Not clammy? Okay.
Cardia.
Yep. So, but if they are on beta blockers, you will not be able to see any of those signs because your beta blockers mask them. So before you realize that, your patient is already on the floor because the blood sugar is
Low.
so low. So I know this is a very, very common question, that if your patient is on, what is that diabetic med? Is on a diabetic medication, we have to watch out if they're also on beta
Blockers.
Watch out, okay? So something about metformin. Is it metformin or glyburide? There's a question about that. So watch out for those because they mask those signs and symptoms of these purposes. We have defined hypoglycemia as blood sugar that is below 70. Now, hey, now we are into calcium channel blockers, your C's. B, calcium channel blockers. These are your verapamil, your nifedipine, and your diltiazem. Is it diltiazem?
I think it's
Zim, right?
mm.
I was like, there's something wrong with it. Okay, diltiazem. So these are your calcium channel blockers. They lower the BP, but not the heart rate. Just the BP, just the blood pressure. The calcium channel blockers, they said, tends to calm the heart down. How? By blocking the movement of calcium. So when the movement of calcium is blocked, cells are not stimulated, cells tend to relax. When the cells are relaxed, the blood vessels are also relaxed. So the blood pressure goes down. So your calcium channel blockers calms the heart by blocking the movement of calcium within the cells. So they only do blood pressure, not the heart rate. So if your patient is on diltiazem and the heart rate was 60, are you going to give the medication or not?
No.
Oh,
No.
Why not?
Yes,
below.
that's
Why?
fine.
Is it because it's below 70?
Mm,
Is that what you said?
diltiazem,
No.
what is that? That is a calcium
Blocker.
Channel
channel
blocker.
blocker. Calcium channel blockers, right?
Mm.
Do they have, can they affect your heart rate?
No,
No.
they only
Yeah.
affect the blood pressure.
Only
Blood
the
pressure.
Yes.
So if your patient is on diltiazem and the blood pressure is the pulse rate is 60, are you gonna give the medication or not?
Yes.
Yes,
Yeah,
we
Can you
give.
give the
because it
medication?
affects the heart
Yes.
rate.
Yes, you're supposed to give the,
Yes.
Medication.
because they lower the BP, but they do not have anything to do with the
Heart rate.
rate. So they calm the heart by blocking the calcium. When calcium does not enter, it does not stimulate, and then you have your blood vessels are relaxed that way. So some of these medications, some of your calcium channel blockers could be given. If they're given IV, we have,
Bless you.
huh?
Oh, sorry.
Oh, I was
That's
like,
me.
what? No.
So-
So if they're given IV, remember the big drops. Okay, you do not want it to drop abruptly. So if it is something that is given IV LPNs, we have to notify the RN to slow or stop the drip. Now we're on to the D's. Digoxin, which is a cardiac glycoside. Ditch. As we said, digoxin lowers the heart rate by increasing contractility, increasing the force of contraction. So they want to have more meaningful contractions, slow but meaningful. So digoxin lowers the heart rate. What do you have to remember here is this is when you answer questions about digoxin, in the ideal world, you have to check the apical pulse for 1 minute. How do you check the apical pulse? Where is the apical pulse?
Left,
Left where?
lower, right underneath the lower quadrant,
Mhm.
Oh, 4 minutes.
right underneath the left by the
Neck, I think is in the neck region.
no apical,
Apical pulse.
like the lower breast area.
Oh yeah, in the ribs.
Yes.
Yep.
So you're checking it directly above the heart with a stethoscope. That is the ideal. That is how you have to answer that. I know in reality, we check the pulse. We even do 30 seconds times 2, right? But here you cannot do it. Here, apical pulse for 1 minute. Now we also know that toxicity for digoxin, right? Level, digoxin level above 2.0. Now, signs and symptoms of digoxin toxicity: nausea, vomiting, anything that changes your visual changes, whatever it is, blurred vision, color changes, difficulty reading,
Yeah, that came up a
anything.
lot.
It does come up a lot, right?
Yeah, that came up a lot.
Select all that apply questions. So anything that has something to do with vision, blurred vision, color changes, difficulty breathing, those are signs and symptoms of digoxin toxicity. We know, of course, we know about nausea and vomiting, right? And then you have your dizziness also. Nausea, vomiting, visual changes, and dizziness. Now, the interesting thing about digoxin also is potassium. Any potassium below 3.5 increases the risk for digoxin toxicity. Digoxin does not lower potassium. It's just that if you have a patient that has hypokalemia and is also taking ditch, it increases their risk for toxicity. So just keep that at the back of your mind. It has nothing to do with digoxin can lower potassium. No, it's just that if your patient has hypokalemia, they're more likely to have digoxin toxicity if they're taking ditch. So, something interesting. Who are more at risk for digoxin toxicity? Those that are taking
Warfarin.
diuretics, right?
Mhm.
Diuretics that are potassium wasting diuretics, and those that have kidney failure. If they can't get rid of the ditch from your system, then it's going to circulate. So you have kidney failure patients and those patients that are on diuretics, that potassium wasting diuretics, because if they have hypokalemia, then it increases their risk for digoxin toxicity. For kidney failure, we always look out for the BUN and the creatinine, right? But although there's both of them, the kidney function lab is always creatinine. So a creatinine level that is higher than 1.3 is very bad for your kidneys. So Now, another D. You're like, stop already. So, another D. This is an easier D. So, you have dilators, right? Your vasodilators used for chest pains and heart failure. What examples of these medications are? Nitroglycerin, right? Nitroglycerin, nitroprusside, hydralazine, isosorbide, and minoxidil. I know you have a lot of questions about minoxidil too. So these are your vasodilators. They open up the blood vessels, decreasing your blood pressure this way. This is used for chest pains and heart failure because when the blood vessels open, there will be more oxygen that could be given to the heart with your coronary circulation. But so nitro makes the blood pressure low. Oh my God, it rhymes. Nitro makes the blood pressure low. So your nitroglycerin can make your blood pressure go low because they're vasodilators. They dilate the blood vessels, increasing the flow of oxygen. Something very interesting, okay? Killer considerations, because you could die here. No AFil drugs when you are on vasodilators. AFil, such as sildenafil. What is the trade name for that?
Viagra.
Niagara.
Viagra, right? No Viagra if you're taking vasodilators. Yes, you could die from that also. Because now you have 2 vasodilators already. So the thing that you just have to remember with your dilators is monitor the BP over and over and over again. They're saying that hold if the blood pressure is 90 to 100 systolic. Monitor for signs and symptoms of hypotension. The earliest signs of hypotension is what? Confusion, lack of coordination, irritability, sweating, and pallor. They're saying that when there's hypotension, there's less oxygenation to the brain. So you will see signs and symptoms of confusion, restlessness, irritability, lack of coordination. You will see those symptoms. Here, normal side effects. Normal side effects. Headaches, hypotension, and hot flashes. Facial redness when you are on vasodilators. Questions? We're still good?
The normal side effects,
Mhm.
because I'm still get confused with the use of these two languages. Like normal side effects, is it expected
Mhm.
side effects?
Yes. So it's not adverse. It's
Okay.
expected. Yeah. It's expected that you'll get a headache. It's expected that your blood pressure will drop. And sometimes you could see facial redness too. So you're not gonna do anything about it because it's an expected side effect.
Okay, thank you.
Sure. One more D. Diuretics. So diuretics decrease the blood pressure by draining the fluid, by dehydrating the heart, right? By excreting all of those fluids, you are decreasing fluid retention, thereby decreasing the blood pressure. Sometimes diuretics are used for heart failure. So these medications end in mostly in ide. So furosemide, so ide, torsemide, Bumex, Bumita, is it? So Bumex also ends in ide. So furosemide, what is the trade name for that? What is it? Lasix, right? So Lasix. Lasix is the first drug of choice for your heart failure patients. What do the diuretics do? They dry the body, dried. They make the body dehydrate by getting rid of all of those fluid. So the body becomes dry. How do they do is they block sodium reabsorption. Without sodium, there's no water. Sodium loves to hold on to water. So if they would not allow sodium back, then water would be eliminated. Your potassium wasting diuretics. There are diuretics that, with the excretion of fluids and all of that, they also excrete potassium. So this is one of those that, and these are your Lasix in them, your furosemide, your torsemide, they are potassium wasting. That's why if you've noticed, if your patient is on Lasix, they would also be prescribed what? Potassium supplements also, right? Lasix and potassium goes together because Lasix is a potassium wasting diuretic. So if your patients are on potassium wasting diuretics, you should give them potassium rich foods. This is very interesting. You guys know licorice, right?
Yep.
Yes. So avoid them, not the red one, but there's a black one, I think, because licorice root, they lower potassium levels for some reason. So you should know this because this will pop up in select all that apply questions also. So licorice root, it's licorice, it's not the red one, but it's kind of like black, but it's still that. It's still a candy, but
It's pretty nasty anyways. It's
yeah,
not worth it.
you don't want to eat that, right?
No.
So it's nasty also, but so you know, and select all that apply questions. If it's there, it should be selected. Now, you have your potassium sparing. These are the medications, the diuretics that does not get rid of potassium. Potassium sparing and potassium wasting. A potassium sparing diuretic is spironolactone. So we have to remember potassium again is a pump, right? So the higher the potassium, the higher the pump. So when you think about pump, you're thinking about muscle spasms and muscle cramps. Okay, so when you think about hyperkalemia, what are the signs and symptoms of hyperkalemia? The higher the potassium, the higher the pump, you will have muscle cramps and muscle spasms. You will, if you have hypokalemia, the lesser the potassium, the lower the pump, you will have weakness and paresthesia. So it has something to do with pump and the muscles. However, on your EKG strip, if you have hyperkalemia, you will have ST elevation and a peaked T wave. So just so that it's there. Do I have that here? No, I don't. Anyway, okay. Guidelines, just so you know, potassium cannot be given IV push. You know what they give people when they're giving them medications to get, what is that, in prison, in death row? When you're scheduled to die on death row, those medications that they give you, one of those medications is potassium.
Yeah, that's right.
Right? Yeah. So you have to remember that. Potassium, and they're giving it directly IV push in that case. But here, you cannot give potassium IV push. You have to give it through the IV, very slow infusion. Not IV push directly. So when you are giving diuretics, look at my spelling. When you are giving diuretics, of course, we already know, hold for low BP. So watch for blood pressure, monitor BUN and creatinine, check before giving. Watch out for potassium imbalance. Slow position changes, okay? So you should remember that now. Because diuretics are usually given for your heart failure patients, right? Daily weights. So if your patient gains 2 to 3 pounds a day, that is something that needs to be reported to the attending physician immediately. You have rash for sunburns, and again, low sodium diet, because we do not want sodium, because what does sodium do?
Retains water.
Retains it.
It retains water. So a low sodium diet. This also comes up all the time. What is in the low sodium diet? No chips, no fried foods, no canned or pre-packaged food. They're so salty.
Miss Stephanie, I have a question. So for when you do the daily weighing the patient daily, you report a gain of 2 to 3 pounds. Is that what you're trying to say? Okay.
Right away. Right away.
Sounds good. Clarification.
And then very interesting fact, I didn't know this, now I do. Avoid over-the-counter medications that are high in sodium. Do you know medications can be high in sodium? Cough and flu medications, antacids, acetaminophen, and NSAIDs, naproxen, and ibuprofen.
How did it go?
Yeah, I didn't know that. Now I do. So these are medications. Yeah, avoid them in case it pops up in your select all that apply questions. Yeah, you can't have it for your diuretics. Just as a side note for you, furosemide is the first choice for heart failure. If you're giving it too fast, ototoxic and hypotension. If you're having it for too long, it could be bad for your kidneys. And are you going to have hyperkalemia or hypo? Hypo or hyper?
Hypo.
Hypo, right? Because Lasix is
Go.
potassium sparing or potassium wasting?
Potassium waster.
Wasting, right?
Yep.
So you will have, if you're on Lasix for too long, you're most probably going to have hypokalemia. But with Lasix, there's always potassium ordered with it. Questions? We're moving into something else. Still cardiac. But so now we're going into dysrhythmias, your anti-dysrhythmias. So I'm just going to tell you that 2 medications that we have in here, they are anti-dysrhythmia. So they are for those irregular heart rhythm. So they are for the heart rhythm. So when you see questions like these, they will probably show you an EKG strip, because this is abnormalities in the heart rhythm. So these are your dysrhythmias. One of these drugs is called atropine. So atropine is given for a very slow heart rate. Atropine is given because of symptomatic bradycardia. So atropine is sometimes given if the heart rate is 38. So you give atropine. Atropine increases the heart rate by blocking the vagus nerve, the action of the vagus nerve, which is to slow down the heart rate. So signs and symptoms of symptomatic bradycardia is mental status change. Why do we say mental status change? It's because there's less oxygen to the brain, because it's a very slow heart rate. So you have confusion, irritability, and agitation. So remember, atropine is it's the rhythm, it's the heart rhythm that is addressed by your dysrhythmia drugs. So the thing that they're telling you here is if atropine does not work, then we have to put the patient on a pacemaker, external pacing. So atropine is there to increase the heart rate, right? Because this is used for symptomatic bradycardia. So on your EKG tracing, you could see this, like 40 beats a minute. Very slow, okay? How would you count the beats on the EKG? What are you counting?
Rhythm?
How would you count the beats on the EKG? Wait. How? I'm trying to find my EKG strip. Is it on this thing? Yes, maybe, I think. If it's not, then it's too bad. How would you count your EKG strips? How would you count the beats? I'm trying to find my slide. Because we're on dysrhythmias. So okay, here it is. I hope. So I'm sharing my screen.
10 seconds.
10 seconds. Okay, here. So this is your normal EKG, right? P, Q, R, S, and T. P, so it's kind of like P, Q, R, S, and T. There's that. So remember earlier we were talking about ST elevation, S, and T, higher ST elevation. Anyway, now, here, this is better. Okay, this is where you have one EKG strip that they're gonna show you on your test. It's probably representative of 1 minute. So this one is sinus bradycardia. It's regular because look, they're evenly spaced, right? But they're very slow. How would you count the beats per minute? Is you just count the peaks, the R's. So 1, 2, 3, and 4. And then you multiply that by 10. So this strip is 40 beats per minute. You just count the peaks. Is how you count beats per minute. What about this?
Oh.
This is tachycardia. So you just count the beats. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. Times 10 is how much?
130.
130.
130. So that is tachycardia, right? Just in case they will give you they could give you strips. They could say between this and this, when would you give atropine? So atropine is indicated for when?
Bradycardia.
Very slow heart rate.
Bradycardia.
Slow bradycardia.
Bradycardia.
Slow heart rate. So between this strip or this strip?
The first one.
The first one, right? Because when you're counting, it's only 1, 2, 3, and 4. Times 10, it's 40 beats per minute. That is just how you count. So if they're asking you, okay, atropine is indicated for A or B. Now you know, because we're into dysrhythmias. So they will ask you questions using EKG strips. Okay, so at least we got that down. At least we got how to count your EKG tracings down. Where's my other stuff? So, okay. So now we're continuing. So now we're saying that if it does not work, then they have to have an external defibrillator. External pacemaker. Oh my God. Pacemaker. So external pacing. Now, the second dysrhythmic drug is called adenosine. Adenosine is the opposite. This is supraventricular tachycardia. So what does this mean? The heart is what?
Pumping fast.
Pumping very fast. So what do you want to do? You want to
Slow it down.
slow it down. So they're opposite of each other, right? Atropine, you want to
Speed it up.
increase the heart rate. With adenosine, you want to slow the heart rate down because it is going too fast. So you see, most of the questions involves an EKG strip. So at least you know that you have that baseline. Now they're saying that before you remember the other one says the atropine works by blocking the vagus nerve action. Adenosine, here, before you give adenosine, let the patient do vasovagal maneuver first. It's kind of like you're bearing down, like you're having a bowel movement. Tell them to bear down first. By doing that, you're trying to stimulate your vagus nerve. When the vagus nerve is stimulated, naturally, it slows down the heart rate. That's what the vagus nerve does too. That's why on the opposite end with atropine is saying they're blocking the vagus nerve action because the heart rate with atropine is already so low. You don't want it to be lowered anymore. So adenosine, tell them to do that first. If it does not work, then you give adenosine through IV push very rapidly, within 1 to 2 seconds, followed by a saline flush. You want to give it, and you want to make sure it reaches there. So you want to push the saline flush also. Why do you have to do it so fast? Because I think the effectivity of your adenosine is only less than a minute also. So if you're taking your time, it's gonna be ineffective by the time it reaches the heart, right? Push 1 to 2 seconds, followed by a saline flush. Okay, that's the one thing that you have to remember for your adenosine. Now, sometimes what do? They give you a shock, right? To convert the heart rhythm, right? Remember, they shock you. When the heart is going so fast, sometimes they could shock you to lower the heart rate, to kind of like wake you up. So,
Wait, Miss Stephanie?
Yeah.
I'm sorry, you said if the heart is beating too fast, and they'll give you to wake you up?
Mm-hmm.
Okay,
Shock.
okay. See, okay.
We call that cardioversion.
Cardioversion, okay.
Cardioversion. They do cardioversion. It's kind of like they give you the paddles also, but it's different from defibrillation. When we do defibrillation with CPR, we do that to what? When there's no pulse, right? Or there's no respiration. When the pulse rate has stopped, we do the defibrillation in CPR, right? Okay. Now, when you do cardioversion, it means that you're shocking the heart, lower the heart rate. That's the difference between defibrillation, where the heart stops and you're trying to wake it up, between that and cardioversion is when you are just trying to stop the heart, shock the heart so the heart rate will lower. Cardioversion. So with your supraventricular tachycardias, you're doing cardioversion and not defibrillation. Going already. So, okay. You still with me? Do you have questions?
Oh,
You're
No.
still alive? Okay, good. Now, the heart. I did say there's not a lot, but it seems like there is a lot. So anyway, cholesterol lowering agents. Your statins, atorvastatin, simvastatin, lovastatin, rosuvastatin. So your statins are your cholesterol lowering agents. They are indicated for high cholesterol levels. How do they work? They prevent the liver from producing cholesterol. So, bad liver, but this medication stops the liver from producing cholesterol. It's indicated when your cholesterol levels are too high. They're also saying it could be hypercholesterolemia or hyperlipidemia. They both mean the same thing. They both mean high cholesterol levels. Now you have your, I always get confused, your LDLs and your HDLs. Well, now, which one is the bad?
LDL.
Oh,
LDL.
LDL.
LDL. I always get confused between the two. So the LDL is the bad. It's the looser lipids. It should be, L should be low. So LDL, you want them low. Your HDL, you want them
Hi.
high because they're the good cholesterol. So worry about them. Okay. Toxic liver enzymes. We have to know that it works on the liver by preventing the liver to make cholesterol by blocking a certain enzyme. So if your liver enzymes are already elevated, you have to watch out for that. For some reason, avoid grapefruit and St. John's wort. It's an over-the-counter medication. Always, when do you take your cholesterol lowering medications?
At night.
At night. You've seen questions like that, right? A very big thing for NCLEX, take it at dinner time or at bedside. So now you know. Notify healthcare provider immediately if your patient is complaining of muscle cramps, muscle spasms, and muscle aches. Muscle. Notify your healthcare provider for those. Here. The question would look like this. Patient on lovastatin, when would the nurse notify the healthcare provider? And the choices would be all of those things. And then your answer should be muscle aches and cramps. You see, this is coming from so many, I think ATI. So you have patient this question, and then it's muscle cramps and aches and cramps. And then here, report new. Remember I said words like new or worsening, you have to pay particular attention. New and worsening. Here, new muscle tenderness. And then report muscle pain and tenderness without injury. So they're just different ways of phrasing the question, but any muscle cramps, muscle spasms, muscle aches with your statins have to be reported immediately to your attending physician. And you should be happy. That's the end of it.
Yay.
Yay! Ah, that was a lot. So when you go back to your books, right? So now you have your notes. Go back to your books and you know how to edit them. The one that we went through are those very common questions that were popping up on your exams about the cardiac system, right? So now you have it. Which reminds me, nitroglycerin. When do you administer that? Nitroglycerin pills
For
are given
As soon as you feel
chest pain.
chest pain,
chest pains and given where?
Down.
Under the
sublingually,
Tongue.
under the tongue.
Sublingual.
tongue? How often?
As soon
For
as you
5
feel-
minutes. Five
Three-
minutes.
Yeah,
For how
No,
long?
but not more than
3
3.
times for 5
3
minutes.
times.
3 times for 5 minutes. And you
Call
don't
911.
and call 911. What about your nitro paste?
Careless.
Careless, please.
Okay. But then you don't want to rub, if you're doing the paste, you don't want to rub it in your fingers also, right?
No,
Medication.
no.
You have to wear
Gloves.
Gloves
gloves.
and
But
cover it.
on your patient's chest, do you want to rub the nitro paste?
No,
No. Why?
It's airy.
just spread it.
Because you don't want absorption to go so fast.
Fast. Yes. I was going to ask a question, ma'am.
Mhm,
When
sure.
you have the nitroglycerin, the one you put in the mouth, the
Mhm.
sublingual,
Yes.
and can you use that with the can you use it the same time with the paste, or can you use the two of them together, like the paste or the patch at the same time?
The patch is supposed to be kind of like a maintenance dose, right?
Maintenance. Okay.
Patch, you change it every 72 hours, right?
Yes. Take it off
The
every 10.
paste, sometimes every 6 hours. But the one that you put, the tablets that you put sublingual are
Yes.
supposed to be for emergency.
Oh,
Okay.
Yeah.
So
So if
even
they're already complaining of chest pains, then you give it to them.
okay.
Stephanie, how often do you give the sublinguals again?
Which one?
The sublinguals. How often do you give it again?
Sublinguals is every 5 minutes times 3. And you're calling 911 too.
After the first one, if it doesn't go after the first 5 minutes.
But you continue to do until 911 gets there. But typically, 1 every 5 minutes times 3 for 15 minutes, right?
yes.
Yes.
What of the spray, Miss Stephanie?
Huh?
So the spray, nitroglycerin spray. Is it under the tongue?
The spray?
Mhm.
I think the spray is,
On the tongue. On the tongue.
yeah,
On, okay.
also. So, yay! So, you feel better now?
Yes.
Right? I know you studied them, so you just need a little bit of a reminder for all of those things, right? So Tuesday, no review on Saturday. On Tuesday, we're gonna do your endocrine, and that's gonna be short and fast, right? And then after that, I will let you go. You can study, and then on February 8th, we're gonna do your first test. Remember though, when you test, okay, if we want to repeat, some of you might want to just move on to ATI Farm, which is fine also. But if you want to repeat, you have to repeat both. You cannot pick and choose just one. If you say, I only want to repeat my second predictor and not the first one, you have to do both. When we're repeating, okay? So, fair enough? If you do
Wait,
not
no,
want to
Miss
repeat,
Stephanie,
yes.
can you repeat that one more time? You said that for the testing, we're only going to repeat one, or what were you saying?
So we're seeing that for the comprehensive farm, the 100 questions on pharmacology. For the PM group, I'm not sure about the morning. Did you guys test the morning people? Not yet, right? The morning people, you don't have to because you haven't started yours yet. But the PM people, they have gone through the two 100 item pharmacology questions, right? You guys did.
Yeah.
Yes.
So you're not just, if you want to repeat, you have to repeat both, okay? You cannot just tell me, I just want to repeat my first one, I want to repeat my second one. We're not going to go that way because then it's just going to get crazy. We're deciding to repeat, we are repeating both.
Yes.
Okay, fair
Okay.
enough?
Okay.
Both. Okay.
Okay.
And
So
then
on the-
the others, if you guys want to move on to your ATI already, and you will let your scores stand for your 100 item pharmacology exam, then we will let it stand and you're moving forward into ATI Farm.
Is that
But
the
if-
schedule for February 8th?
Yes.
Okay.
So, but if you guys want to repeat, we have to repeat both, okay? We have to repeat both. But if you guys want to let your grade stand, then we'll let your grade stand for both, and then you're moving forward into your ATI Farm.
All right, Miss Stuff, I got a question on the 8th of February.
Mm-hmm.
So what time is the test? How are you gonna do it? Because you mentioned that you were gonna separate us, the 6.
Yeah. So there is, I don't know how many of you. So I would have to separate you. You have to tell me. I will put out the time slots, Jay. I know there's some of you that are available earlier. And
In the
there's some of
morning,
you that are, right?
Yes.
So if we can start at 3, and then 5, and then 7.
Okay.
So you're not even overlapping with each other.
Okay, that's fine.
Okay.
So,
Will we be doing them in the morning then?
evening.
Evening. Okay, so
Yeah.
no.
No earlier than 3.
Yeah, we're sticking to your schedule. The
So you
morning
want us to give you the time when we're available?
I will post like February 8th who's available at 3, and then you just let me know. And then
I can do 5. Only
You
at
can-
5. After 5.
okay, so 5, and then the next one after
No,
5.
3 is good. I want to do at 3.
Okay,
Yeah.
so I
No,
will.
Winnie, you can't.
John, I get my hands on you.
You're like, John, forget it. So 3, 5, and 7. Okay. So we're not overlapping. The test is an hour and a half. Those people that are just taking ATI, you're only there for an hour. So we don't overlap.
Okay.
Miss Stephanie,
Does it mean that the 100th question and the ATI are going to be you are going to take place simultaneously?
Yes.
Like some will be doing ATI, some will be doing 100 questions.
Yeah.
Oh.
Some, if we say you're available at 3 o'clock and you want to take an ATI test, you can. You can all be scheduled at 3 o'clock. Some will be doing ATI, some will be doing the question test.
Okay.
We can do both. I can process both.
And this will be at the school, right?
Yes.
Yes.
We don't
And
want
we
to
can
get
bring
into
our own
that
laptop?
anymore. With your own laptop.
Okay.
Oh, okay.
Yeah.
Miss Stephanie, what about for our class, like Hala, Kimberly,
Your
Charles?
class, yours will be Friday, right? So your table will probably change. We're done next Tuesday, so yours is probably going to be 8, 9, 10, 11, like the 12th, Friday. You would also have to come to the school. And there's a few of you. I will post your schedule, Angie, for your class too.
Okay, you want us to go to school as well?
Yes. All going to the school
exam
because
is
we don't want
defined.
any trouble anymore. Yes, Dina?
Funny.
Yes.
I mean, the rest of the exam, so we have to go to schools.
Yes.
Okay.
Yes.
Okay.
Plan on it because we don't want any more trouble. Okay. We don't want any more temptations.
Okay.
Right? Yes. So if there's nothing else.
Miss Stephanie?
Yes.
For the adenosine?
Yes.